In this podcast, we'll be discussing the frequent complaint of abdominal pain. We'll discuss all 4 quadrants, as well as presentation in both the male and female patient. As usual, we'll start with taking a good history. Remember to ask things such as onset, anything that makes the pain better or worse, the quality of the pain, radiation, severity, and timing. For your review of systems, focus on pertinent positives. These include nausea, vomiting, chest pain, urinary symptoms, vaginal or penile discharge, testicular pain, and back pain. Remember, epigastric pain could be an acute coronary syndrome equivalent, so think of your chest pain risk factors, such as hyperlipidemia, hypertension, diabetes, family history, tobacco use, and simply being a male. Next, you'll want to review vital signs, complete a physical exam, and any bedside tests which will further evaluate the pain. When it comes to orders, always start with treating the symptoms, pain medication and nausea medication. For lab work, you'll want to order a complete blood count, complete metabolic panel, lipase, urine analysis, and a urine pregnancy test for females. When it comes to imaging, once again, it's really going to depend on your exam and labs. Depending on that, you might get a CT, ultrasound, both, or none. Let's discuss a few specific examples to help you choose the best imaging technique. Elderly patients are going to receive CT scans more often. That's because they have a lot of potential for things going wrong. Patients with tender abdomens, peritoneal signs, or evidence of appendicitis versus diverticulitis will also likely get a CT. If nephrolithiasis is high on your differential, consider a non-contrast CT. While a patient who has right upper quadrant pain, epigastric pain, and you suspect gallstones will need an ultrasound. Normal labs with a young patient who has a benign abdomen may lead to no imaging at all. Let's discuss our differential diagnosis. You'll want to consider appendicitis, diverticulitis, esophageal rupture, otherwise known as Boerhaave syndrome, gastroenteritis, pancreatitis, perforated ulcer, esophagitis, inflammatory bowel disease, volvulus, cancer, ruptured ovarian cyst, ruptured ectopic, endometriosis, ovarian mass, and pelvic inflammatory disease. In addition, you'll want to consider nephrolithiasis, diabetic ketoacidosis, ruptured abdominal aortic aneurysm, mesenteric ischemia, sickle cell crisis, referred pain from MI, referred pain from pneumonia, and herpes zoster. Your disposition plan is going to depend on your ultimate diagnosis. Generally, well-appearing patients with normal labs, benign abdominal exams who tolerate POs will go home. Patients with emergent findings, appendicitis, pancreatitis, diverticulitis, etc., will be admitted to the appropriate service. Well, that's it. You made it through another podcast. Thanks again for watching.